Okay, because when we are sitting here, we hear a lot of echo, so awesome, thank you. So good afternoon again. My name is Sumit Pruthi. I'm a pediatric neuroradiologist at Vanderbilt Children's Hospital. Oh, it's just projecting well? Yes. So first of all, I want to thank my colleague, Dr. Asha Sarma, who's my partner in crime, my two excellent pediatric neurosurgeons who I work with, Dr. Vellens and Dr. Bonfield, who provided some key images for this talk. I have no disclosures which are relevant to this talk. Now, in the next probably 30 minutes or so, I'm going to talk about congenital spinal anomalies with a focus on imaging modalities, normal anatomy and variants. And I'm going to restrict this talk only primarily to spinal dysraphism or spinal cord anomalies. I'm not going to go into the detail of vertebral anomalies. So let's start. Neural tube defects are the second most common type of congenital anomaly after congenital heart disease. Spinal dysraphism is a term that is used to describe a subset of neural tube defects which happen between fifth to 6 weeks of gestation, and all of these eventually lead to incomplete fusion of either the mesenchymal, osseous, or nervous tissue, just to make it simple. However, in real practice, in our day-to-day practice, the term spinal dysraphism, spina bifida, they're used synonymously, and they're used to describe a heterogeneous group of disorders outside the setting of neural tube defects. For example, people use spinal bifida or spinal dysraphism to describe unfused spinous processes as well. That's not correct, but that's okay. Now, if you're truly speaking about spinal dysraphism, which are a subset of neural tube defects, they're multifactorial in etiology, comprising of genetic, environmental, and nutritional component, of which the most common is folate deficiency. And because of folate supplementation during pregnancy, the incidence of open neural tube defects have significantly gone down. Now, neuroimaging is very, very critical to diagnose the entity, to detect associated anomalies, for therapeutic planning, and assessing post-op complications in patients with spinal dysraphism. It's important to remember that a patient with a single anomaly may have multiple associated anomalies. For example, a patient with lipomyelomeningocele may have an associated split cord malformation or a dermal sinus tract, and we'll see a lot of examples. Now, the spine can be imaged using a variety of techniques. The initial evaluation with plain radiography often begins with portable views of the chest and abdomen obtained in the neonatal period, not just to look for the spine, but for the global assessment. But they provide a lot of information. Now, if you look at this patient with bacterial anomaly, this patient actually has a dilated esophageal pouch, so he has a tracheoesophageal fistula. His heart is big. He has a segmentation fusion anomalies. Of course, he has bowel obstruction because of anolectal malformation. Similarly, this is the patient in the middle is a patient with Currarino triad, which is a triad of sacral agenesis or dysgenesis, anal stenosis, and presacral mass. And you can see that this patient has what we call a scimitar sacrum or sickle-shaped sacrum, and has proximal large bowel obstruction because of anal stenosis, and has a presacral match which is not well visualized on this plain radiograph. Sometimes these patients are referred to us from an outside facility. They're older in age. They have constipation, they have fecal incontinence, and you do a radiograph, and you'll be surprised to see findings like this, where you see absence of the coccyx and the distal sacrum, and the proximal sacrum is dysplastic. So this was a case of caudal regression. So we don't obtain plain radiographs just to look at the spine, but they provide some key information. Similarly, CT scan, because of its excellent multiplanar reconstruction capability and 3D format capability, is primarily used to assess for associated osseous anomalies. And the 3D formats beautifully demonstrate the osseous anomaly. So this was a patient with a large thoracic meningocele. You can see that there is fusion of ribs, distortion of the anatomy of the left hemithorax, but you can beautifully see the segmentation fusion anomalies in the thoracic spine. This is a patient with Sprengel deformity in the setting of Klippel-Feil syndrome. So this patient had multiple segmentation fusion anomalies of the cervical spine and then had a Sprengel deformity. It beautifully depicts all the osseous abnormality. Now, that being said, if you know what you're looking for, you'll find on a CT scan. So this was a case, actually came to us last week. The history was anal stenosis. We did the CT scan of the chest, abdomen, pelvis, and we saw a horseshoe kidney, which is not well seen on this single sagittal image. But if you look closely, this patient has a lipoma and a low-lying cord. So if you know what you're looking for, you may find it on a CT scan. The two most common modalities that are used to image the diverse anatomic anomalies that characterize the pediatric spine, or ultrasonography and MR. Ultrasound is primarily used in neonates and as a screening modality, and MRI is the most definitive or sensitive modality. So let's start with ultrasound. Now, ultrasound is very easy to perform in neonates because the posterior arch of the vertebrae is not yet ossified. So it provides a perfect acoustic window. The sonographic examination usually is performed in a warm room, with the patient usually lying in a prone position. One can obtain imaging in left lateral decubitus positioning. Now, feeding the infant and placing a warm blanket creates magic. The examination is very, very easy, such simple step. Similarly, just placing a towel underneath the pelvis flexes the pelvis and open those unossified arches more to allow better visualization. So these are some steps that can make the exam very easy to perform. Now, imaging is performed both in the longitudinal and transverse plane. And the longitudinal images clearly depict the cord, which appears as a linear hypoechoic structure as seen here. And then it tapers to become the conus. We can easily see the phylum, the chordae equina nerve root. Now, the extended field of view imaging, or what we call as panoramic imaging, or cine imaging, can be obtained. And the beauty of these images are that they can depict the entire neonatal spine spanning from T12 all the way up to the coccyx. And you can see all the structures I just mentioned beautifully as seen on this cine video. Now, the spinal cord produces rhythmic motion because of systole and diastole, and that can be assessed using M mode. And if you have the normal motion, it's an indirect sign that the cord is not tethered. It's not a definite sign, but an indirect sign. And one thing we always do for our spine imaging, we always assess the craniocervical junction, which is beautifully seen here, to look for any tonsillar herniation. On transverse images, one can see the central echocomplex. Now, the central echocomplex is seen on longitudinal image as well, but it's beautifully depicted on transverse image. And it's the imaging marker, a hallmark of spinal cord on ultrasound. And this is very important because if you're dealing with conditions such as diastematomyelia, split cord malformation, or if the cord is completely squished or displaced by an subjacent mass, if you know, it increases the confidence whether you're looking at the cord by locating the central echocomplex. It was initially thought that the central echocomplex represents the central canal, but that's not true. It's actually the interface between the anterior commissure and the median anterior fissure. The transverse images are also very important to assess the posterior convergence of the posterior elements. We can also see the phylum, the chordae equina nerve roots. Some people do dynamic imaging. They place the patient prone and they place the patient on left lateral decubitus, both sides, and see if the chordae equina nerve roots can move freely. So that's also an assessment for tethered cord. Now, it's important to remember that coccyx is not ossified at birth. So if you do a transverse imaging to the coccyx, it can look weird like this. So do not confuse an unossified coccyx with a fluid collection or an abscess. And that is not a dilemma if you're doing a cine images in a longitudinal plane. Let's start with the first question. In a term neonate, what is the lower limit of normal for termination of conus medullaris? Is it T12 L1? Is it L1 L2 disc space? Is it L2 L3 disc space? Is it L3 L4 disc space? Any takers? Correct. Awesome. C is the correct answer. Now, at any age, including term neonate, the lowest limit for normal for conus is L2, L3 disc space. What I'm trying to say is that anytime the conus is below the L2, L3 disc space, it's a low-lying conus. Now, if you look at the mean positioning of the conus in human population, in adults it's about lower T12 and upper L1, and in majority of pediatric population, it's mid L1 level. Now, how do we assess the position of conus in ultrasound? Now, the best way to determine the position of conus is by identifying the lumbosacral junction, which actually happens at the lordotic angle between the lumbar L5 and S1. So there's always an angle you can see, and if you identify that angle, you know that's where the lumbosacral junction is, and that's how you start counting and numbering. Now, it's easier said than done. Sometimes you don't see the lordotic angle. So what you can do is you can flex and extend the pelvis and find the position of the fulcrum in a dynamic assessment, and you can see that lordotic angle. Now, that being said, there are certain scenarios where you don't see the lordotic angle at all, as seen on this picture right here. Then what do? Now, you can still look for a little subtle change in the angle, where the S5 and L5, the S5 is angulated this way, the L5 is angulated this way. And in last scenario is what you can do is you can assess the position of conus by ultrasound, place a BB marker, and then obtain a radiograph and then assess the position of conus. So there are multiple ways to assess the position of conus on ultrasound. Let's talk about some imaging variants on ultrasound. The two most common variants that usually we see are asymptomatic and often detected incidentally. These patients are getting scanned for a sacral dimple, which I'm going to talk on my next slide. And that include filar cyst and ventricularis terminalis. Now, the term filar cyst and ventricularis terminalis is unfortunately often used synonymously. I think they're two distinct entities located in two different locations. A filar cyst appears as an oblong lucency as seen here along the proximal aspect of the filum. For some reasons, maybe because of slice thickness, it's very difficult to visualize on neonatal MRI. And it's primarily seen in neonatal periods. So if you scan after 2 months or 3 months of age, the chances that you'll find a filar cyst is less likely. Moving on to ventricularis terminalis, which is also known as fifth ventricle or terminal ventricle. This is an ependymal line cavity within the conus communicating with the central cord. Now, this is also an incidental finding. However, this can be confused with a distal cord syrinx. Let's talk about sacral dimple. We get a lot of requests to image sacral dimple with ultrasound. So how do we define a simple sacral dimple? A simple sacral dimple is a sacral dimple that is located at the coccyx no more than 2.5 centimeter above the anus. And there should be no associated cutaneous mass. If you look at this recent meta-analysis, they concluded that the incidence of spinal anomalies in kids with simple sacral dimple is exactly similar to patients without sacral dimple. So what does that relate to? Which means spinal ultrasound should not be routinely performed in kids who have simple sacral dimple. However, if you have a red flag, then imaging is warranted. So what are those red flags? So let's look at some red flags. So if the dimple is above the gluteal cleft, of course, if there's a hairy patch, if there are skin changes such as hemangioma or a skin tag, if there are caudal appendages such as tail or a pseudotail, of course, if there are associated neurologic signs and symptoms, for example, bowel and bladder dysfunction, lower extremity weakness, and patients who have syndromes or pre-existing syndromes, particularly the two syndromes which have a high incidence of spinal anomalies, is the OEIS, which is omphalocele exstrophy, imperforate anus, and spinal anomalies, and vectoral anomaly. Okay, shifting gears to MR, I'm going to start with the question again. What's the most accurate way to designate vertebral numbering on MRI? Is it to designate the first non-rib bearing level as L1? Is it to designate the last full disc space as L5, S1? Or should we start numbering downward from C1 or C2, or we just should start numbering down from the level of fifth rib? Any takers again? I know the crowd is very smart here. Oh, I should have mixed it up. Okay, C, the correct answer. So again, this is important because there is least variability in the number of cervical vertebrae. Outside of syndromic patients, most of the human population has 7 cervical vertebrae. As opposed to that, a lumbosacral transitional vertebrae is a very common finding. And because of this reason, for all our spine MR imaging, whether it's a thoracic spine or it's a lumbar spine, of course for a total spine, we include a sagittal image to count all the vertebral levels from top to bottom. This is extremely crucial. If you don't do this, this is one thing you should take from this talk, is to do a sagittal T2 count image so that you can do accurate counting. We also, on our spine MR protocol, include a large field of view coronal image, which is extremely helpful according to my experience. It shows the transitional vertebrae with more accuracy. It shows the segmentation fusion anomalies. Most of these patients have scoliosis. It can show you the curve. It can show you the paraspinous soft tissues much more beautifully. It can distinguish a hypoplastic rib from an elongated transverse process. So these two large field of view images are our workhorse, whether we are doing a total spine imaging or a lumbar spine imaging or a thoracic spine imaging. Of course, all our spine protocols includes the sagittal T2 and axial T2 through the entire spine if you're doing total spine or from the area of interest. Now, because we are adding the sagittal T2 and coronal T2, we have to save time because spine imaging can be a very long procedure and these kids are sedated. What we do is we do not obtain axial T1 through the entire spine. We only obtain axial T1 from conus all the way to distal thecal sac to assess for fatty phylum, phylum lipoma, and spinal lipomas. But we also include the femoral heads. So we extend our field of view, and this is very important because sometimes if you don't know if there is marrow infiltration, if this is fatty marrow, that femoral head acts as a tiebreaker to look at the marrow in the femoral head. So we do an axial T1 and include the femoral heads. Now there are additional sequences which we can obtain on a case-by-case basis, or when we are dealing with certain pathologies, for example, DWI or heavily T2-weighted imaging, which depending on which vendor you're using, it's called KISS or Fiesta or BFFE, and then post-contrast. And I'm going to show some illustrative examples of how these sequences are used. Now, this is beyond the scope of this talk, but this is my search pattern. I'm not going to talk about every element. I'm just going to list the thing. When I'm looking at a spine MR, I start with vertebral numbering, and then I look for the alignment, and I look for body height and disc spaces. I look for cord signal, look for anomalies, both osseous and cord anomalies, look for position of conus, look for phylum, if it's thickened, if there is infiltration, how are the cardiac one and nerve roots, are they clumped, are they free? Are there masses within the cord, outside the cord, you know, the whole spiel of intradural, extradural, intramedullary? Is there a presence of syrinx? I always assess the foramen magnum and the posterior fossa, whatever the view is available. And of course, we all look at paraspinous soft tissues, particularly the distal sacrum, distal anus and kidneys, because there's high incidence of kidney anomalies in kids with spinal dysraphism. I want to reemphasize the point again, which I said in my last slide. It's like, whatever numbering convention you use, whether you call the transitional lumbosacral vertebra as S1 or L6, or some people call it L6, L5H, but have a standard convention, because having that standard convention acknowledges the possibility of transitional anatomy and avoids wrong side surgery. Let's start with a little boring stuff, the embryology. Now, embryology and the embryologic development, of spinal cord is crucial to understand the pathogenesis and at least the classification of spinal dysraphism. And it encompasses three important steps: the gastrulation, the primary neurulation, and secondary neurulation. I'm going to try to make it very simple. Now, gastrulation is the first step. It's very simple. It converts, a gastrulation is a process where a bilaminar disc, embryonic disc, is converted to a trilaminar embryonic disc. It starts with the formation of something called a primitive streak, which then forms the primitive node, and then it grooves on itself, called the primitive groove. Now, not only this starts at the caudal end of the embryo, it organizes the embryo, the axis of the embryo. It organizes what's the cranial end of the embryo, what's the right side of the embryo, what's the left side of the embryo. Now, it also does that this primitive streak stimulates these epiblast cells to produce more cells, which invaginates between the two layers by a process called as invagination. And eventually, all these three layers of cells are completely replaced, and we have the final ectoderm, mesoderm, and endoderm that is formed in the embryo. At the same time, an important structure is formed during gastrulation, which is called the notochord. Now, notochord plays a very important role in the formation of neural tube, as well as thoracic and abdominal viscera. Moving on to primary neurulation, I'm hoping this video is going to work. So once the three layers are formed, which is the ectoderm, the mesoderm, and the endoderm, and this is the notochord, that notochord identifies a portion of the ectoderm, which then becomes the neural plate. That neural plate is again stimulated by the notochord to form the neural fold, the neural groove, eventually the neural tube. And once the neural tube is formed, the cutaneous ectoderm separates from the neural ectoderm. The neural crest separates from the cutaneous ectoderm. So this is the neural tube, and this forms the majority of the spinal cord. The cervical cord, the thoracic cord, and the upper lumbar cord, including the brain, is formed during the primary neurulation. These forms the ganglion cells, these forms the vertebrae, and then you have formation of majority of the spinal cord, except for the distal aspect of the cord. Now, then comes the last step in embryology, which is called the secondary neurulation, where the solid mass of totipotent cells are formed, which is called the tail bud. Now, it's solid to begin with. Subsequently, it goes internal cavitation and forms another tube called the secondary neural tube. And the two tubes join together to form a contiguous tube. And then, with a process called as retrograde dedifferentiation, as you can see here, the tail bud regresses and leads to the formation of the distal cord, the conus, the phylum, and distal spinal cord. So there are three steps: the gastrulation, which converts the 2 layers to 3 layers, forms the endoderm, ectoderm, and mesoderm; the primary neurulation, which forms the primary neural tube, which then leads to the formation of brain and majority of the spinal cord; and secondary neurulation, which forms the distal aspect of the spinal content. Now, if you look at this illustration, the secondary neurulation is happening at a very important time where there's separation of cloaca happening and other organs that are forming, particularly the external genital organs. Hence, any genetic abnormality in this stage is often associated with multiple anorectal and urogenital anomalies. Coming to the meat of talk, so spinal dysraphism, they're classified. First of all, there are multiple classification systems. The most widely accepted classification is the clinical radiologic classification. The clinical component is basically dividing them into open spinal dysraphism and closed spinal dysraphism. In open spinal dysraphism, the neural structures are exposed to an external environment, so there's no skin covering. So that's a clinical aspect. And then in closed spinal dysraphism, the structures which are covered by skin or subcutaneous tissues. So what are some of the common open spinal dysraphism? Includes myelomeningocele, myelocele, myeloschisis, and hemimyelomeningocele. These two are exceedingly rare. I have not seen them. I'm not going to talk about them. Now, when we talk about closed spinal dysraphism, they're further subdivided into three distinct categories, or three distinct buckets. So one, of course, they all are skin covered and covered by subcutaneous tissue. One, if they have a big subcutaneous mass. If they have a big subcutaneous mass, they're subdivided based on what the content of the mass are. For example, it's lipomyelocele if it's fat and neural tissue. Lipomyelomeningocele if it's fat, neural tissue, and meninges. Or meningocele if there's only meninges. And then myelocystocele. And I'm going to talk about most of these entities in my subsequent slides. Now, if there's no subcutaneous mass, the closed spinal dysraphism is divided as complex defects and simple defects. The complex defects include dermal sinus tract, diastomatomalia, which is now called a split cord malformation, chordal regression or chordal agenesis, and limited myoschisis. And the simple dystrophic defects are divided into fatty phylum, tight phylum syndrome, and terminal ventricle, which we saw as a variant during ultrasound. So my last question, but not the last slide. What is true of tethered cord syndrome? Is it primarily an imaging diagnosis? Can present without low-lying cord conus? Upper extremity weakness is typical. Scoliosis is unusual. Awesome. I thought people would say C because I had a trend of C going on. Yes, so it can present without low-lying conus. So what's the definition of tethered cord? It's a very simple definition. There's pathologic fixation of spinal cord, usually, but not always, in an abnormal chordal location, which then leads to mechanical stretching, distortion, and eventually ischemia with growth and development. So the cord is tethered, and the spinal canal or the bony canal is growing. That causes mechanical stretching, then causes ischemia, and then causes symptoms. It's important to remember that cord is by default tethered in all open spinal dysraphism, and most of the spinal dysraphism with subcutaneous mass or complex dystrophic state. So you don't have to mention that the cord is tethered. Physiologically, the cord is tethered in most of the cases of open and closed spinal dysraphism with subcutaneous mass. Now, outside of the setting of these entities, the two most common abnormalities which we see in the setting of tethered cord is a low-lying conus, which means the conus below L2, L3 disc, which we saw earlier, or you can have a normal position conus with a thickened phylum, which also people call as tight phylum syndrome or tight phylum fatty syndrome. Now, as I said in my question, that tethered cord syndrome can be purely a clinical diagnosis. There's a very, very small subset of patients where the imaging is completely normal, conus is normal in position, the phylum is not thickened, and they have all the symptoms of tethering. So what are these symptoms of tethering? And the mnemonic is very easy. It's called conus. The mnemonic is conus. So it's cutaneous, which means patients have hairy patch, hemangioma, or dermal appendages. These patients have high incidence of orthopedic problems such as scoliosis, clubfoot, toe walking, pes cavus. They, of course, have neurologic problems such as weakness, numbness, and tingling. They have neurogenic bladder, they have fecal incontinence, they have bowel dysfunction, for example, constipation, and of course, they have back pain and leg pain. So a constellation of these findings is sufficient to diagnose tethered cord in the setting of normal imaging. However, I would still say about 90% of the cases, imaging is very helpful and is abnormal. And what are the spectrum of phylum abnormalities that we can see in the setting of tethered cord? So of course we can have Of course we can have a normal phylum with a low-lying conus. We can have just fatty infiltration without thickening. We can have thickened phylum without fatty infiltration. We can have thickened phylum with fatty infiltration. And we can have obvious phylum lipoma. So let's, first of all, decide what's the normal thickness of the phylum. So if you look at all the studies, the mean thickness of the phylum, you're safe to call phylum normal if it's less than 1 millimeter. And you are safe to call phylum thicken if it's more than 2 millimeters. There's no controversy. Less than 1 millimeter, whether it's sonography or MR, 100% normal. More than 2 millimeters sonography or MR, abnormal. The gray zone is between 1.5 to 2 millimeters. And this patient actually, this measurement is not projecting well, it was 1.6, and this patient had tethered cord. Now, also want to highlight a very important point. All these findings which I've displayed on this slide can be purely incidental, including a phylum lipoma. In fact, we see a lot of incidental phylum lipoma. So in the absence of tethered cord syndrome symptoms, most of these findings, particularly fat infiltration, or a phylum lipoma, or a thickened phylum with fat infiltration, all of these are incidental findings. Okay, let's start with myelomeningocele, which is the most common type of open spinal dystrophism. Again, it's a failure of primary neurulation, accounts for 98% of open spinal dystrophism. Lower lumbar and sacral area is the most common affected. Now, these patients don't have a distal cord. They don't have a conus. They don't have a phylum. What they have is a neural placoid. And when I was under training, I had no clue what neural placoid means. People just call neural placoid because what is neural placoid? So basically, neural placoid is a portion of neural tube which is stuck in the primordial stage. It never became, it was not stimulated by the notochord. It never evolved into a neural groove or a neural fold or a neural tube. So basically, if you imagine this tube had to become a fold, so the surface which is exposed should have been the internal surface of the central canal of the cord. So this is getting, this ependymal surface, which should be the central canal, is exposed to the amniotic cavity and gets damaged. Most of these patients are associated with Chiari-2 malformation, and the clinical spectrum depends on the length of involvement and the damage to the placoid. Now, diagnosis is usually made with obstetric ultrasound, and fetal MRI is the modality of choice. It's usually performed after 20 weeks of gestation. On MR, one can easily see lack of skin and subcutaneous tissue with herniation of neuroplacoid, as you can see on the image in the middle. MR is also very important to assess intracranial findings of Chiari-2 malformation, such as hydrocephalus, the degree of tonsillar herniation, the degree of hindbrain malformation. Now, antenatal repair is now becoming a routine part of care for these patients. In our hospital, most of these myelomeningocele patients are repaired antenatally. And this is a great example of a patient who has a large lumbar myelomeningocele, who was operated. This is a follow-up fetal MR, which shows that the placoid is no longer exposed to the environment. But look at this, dramatic improvement in the posterior fossa. The hindbrain herniation is gone. So this is a revolutionary surgery. They have a very low incidence of need for shunting. The incidence of hydrocephalus is less. They have better scholastic achievement. They have better motor outcomes when they are repaired antenatally. Now, after repair, after postnatal, after birth, most of these patients will still have some residual neurologic defect because they don't have a well-formed cord. They have a neural placoid. So any clinical deterioration after birth implies complication. And what are those complications? They can be divided into 5 broad categories, which are like immediate post-op complications, which means the dura may be pulled too tightly over the placoid, or ischemia happened during surgery or right after surgery, or the spinal cord can become retethered, or the cord is being compressed after surgery because of an inclusion cyst or an arachnoid cyst. And last but not the least, there's a syrinx that is formed, or there are additional CNS complications because these patients have Chiari malformation. Only the top 3 can be imaged using MRI. Now, as opposed to my screening protocol, which I talked about earlier in my slide for all our myelomeningocele patients, post-op patients, we definitely add heavily T2-weighted imaging, DWI imaging, and on a case-by-case basis, post-contrast imaging. Now, the first complication is the cord is retethered. Now, it's extremely difficult to diagnose retethering based on imaging alone, because this is how post-op imaging looks like. The placoid will be always low-lying. It'll always be posteriorly directed. It'll be adherent to the scar dural interface. So how do you diagnose? So just by looking at the scar interface, because the placoid is low-lying, you cannot call that the cord is retethered. The only imaging evidence that can help you that the cord is retethering is the presence or worsening terminal syrinx. Of course, the cord can be compressed by an inclusion cyst, and DWI imaging can be very useful. So this was a case with a large cyst. It could be an epidermoid cyst, could be a dermoid cyst, could be an arachnoid cyst, but you can see that DWI imaging is showing restricted diffusion. This was a post-op epidermoid cyst in a patient status post myelomeningocele repair. Similarly, heavily T2-weighted imaging is very important in assessing post-op complication to distinguish thecal sac ectasia. This is a normal finding. This is how post-op meningocele patients will look like. Low-lying plaque cord, a little bit of thecal sac ectasia, but heavily T2-weighted imaging can distinguish the thecal sac ectasia from an arachnoid cyst. Again, I'm not sure if it's projecting very well. There's a thin membrane that goes all around, or a terminal serings, or from loculations. Moving on to myelocystocele. So what is myelocystocele? Myelocystocele is herniation of a syrinx cavity. So it's like a cord syrinx, which is herniating through a bony defect into a meningocele. That's a myelocystocele. And they can happen at any level of the spine. And depending on where they happen, they're classified as terminal when they're located in the lumbosacral spine, or non-terminal when they happen in the cervical and thoracic spine. Now, OEIS complex, which I mentioned earlier, is usually associated with terminal myelocystocele. Now, non-terminal myelocystocele, they happen in the cervical region, thoracic region, and upper lumbar region. Just like myelomeningocele, they're often picked on fetal MRs, and they exactly can look like myelomeningocele. So how do you distinguish this, which is a non-terminal myelocystocele, from a myelomeningocele? So these are the way you can distinguish a non-terminal myelocystocele from a myelomeningocele. Unlike myelomeningocele, the neural tissue is not exposed to the environment. Now, this finding cannot be easily seen on imaging. However, Chiari malformation, which is seen in about 100% of cases with myelomeningocele, is only seen in about 50% of cases with myelocystocele. Similarly, these patients with myelocystocele have only mild posterior fossa deformity. They have less tonsillar herniation, less hindbrain herniation, less hydrocephalus. So all the intracranial findings are less severe. And both, comparing the non-terminal myelocystocele to my myelomeningocele and terminal myelocystocele, most of these patients actually do not show any neurologic impairment right after birth. Whereas in terminal myelocystocele, most of these patients right at birth have significant neurologic dysfunction and bowel bladder dysfunction. On imaging, to make things complex, the non-terminal myelocystocele are divided into two further subtypes, where the abortive type, where the meningocele is crossed by a stalk, fibroneurovascular stalk, or the complete type, where the syrinx cavity completely herniates into the meningocele. And this is an example from our hospital. It's somewhat low-lying, but this was a case of non-terminal myelocystocele, where you can see beautifully the fibroneurovascular stalk extending all the way. And this patient had no intracranial findings. And by the way, this finding can also be easily seen on an OB ultrasound. Moving on to spinal lipomas. According to me, these are the most common things I see in my day-to-day practice. They're very complex, heterogeneous entities. There are multiple classification systems. They want to make our life difficult. Now, there's an imaging classification where they divide it into lipoma with dorsal dural defect, which is just a fancy name for a closed spinal dysraphism with an associated subcutaneous mass. So these patients have closed spinal dysraphism with a large subcutaneous mass, and they have a dorsal defect. And again, just depending on what the content herniating, they are on a continuum of lipomyelocele, lipomyelomeningocele, and lipomyeloschisis. The second imaging classification is intradural lipoma, where the lipomatous component is completely confined in the thecal sac or within the dura. Then there's surgical classification. The surgical classification is primarily based on the morphology of the lipoma in relationship to the spinal cord. Now, I don't want you to pay attention, just want to show that there are multiple classification systems. Now, of which Pang's classification was the first to introduce embryologic perspective into the classification of spinal lipoma. And they divided lipomas into four types. The dorsal type, basically where the lipomatous component is dorsal to the distal cord and the conus is relatively normally formed. The transitional type, where the lipoma is dorsal but definitely inferior to the conus, and conus may or may not be normally formed. The chaotic type, where the conus is not normally formed and the entire nerve roots are completely entangled with the lipoma, so it's a big chaos happening. And then the terminal type, where everything is normally formed, the conus is normal, the distal cord is normal, and the patients only have phylum terminal lipoma. So this is Pang's classification. Now, I don't think people will remember this. So what is important for us as radiologists? What are our neurosurgeons looking for? Of course, they're looking for the size and location of lipoma. In addition to the size and location of lipoma, they're looking for three important things. Is there a presence of sinus tract? Because if there's one, they need to probe the tract and they need to completely resect the tract. And if there's a dural defect, they want to know how big the defect is, because the bigger the defect, the more problematic the dural repair will be. And the third thing they want to know is how chaotic the lipoma is. If the lipoma is completely entangled with the nerve roots, the gross total resection capability goes dramatically down. So from radiology perspective, all they care is there a sinus tract, what's the size of dural defect, and how much entanglement of the nerve roots are there. Now, the treatment of fatty phylum lipoma is surgical untethering, which happens by just sectioning the phylum at the level of the conus, and this is how a normal post-op appearance looks like. They don't resect the entire phylum, so if you see a little fat, that's completely normal. That's a good response to treatment of post-surgery, post-operation. It's also important to remember that spinal lipomas can significantly increase in size, particularly in the first few years of life, and particularly after first few months of life, because the size and growth is closely correlated with the physiologic growth of subcutaneous fat. So as the subcutaneous fat grows and the BMI grows, the lipoma will grow. So that's why we have to have more shorter follow-up in younger kids post-op spinal lipoma. I'm almost done. 2 more entities left. Thank you for bearing with me. Dermal sinus tract. It's a fistula lined by epithelium that connects the skin surface with the CNS. The definition is simple. Lumbosacral region is the most common site. Now, it can connect to any level of CNS and can cause complication because the CNS is now exposed to the skin surface, so it can cause meningitis, abscess, and CSF leak. On MR, you can see a thin band which courses through the subcutaneous tissue with an oblique trajectory. It can be oblique ascending trajectory, or it can be an oblique descending trajectory. Now, the 3 most common entities we see sinus tracts is basically a tethered cord with a terminal syrinx, an epidermoid or a dermoid cyst, and of course, spinal lipomas. Just like myelomeningocele, we do obtain heavily T2-weighted imaging and DWI imaging. This was a patient who had a cyst with a dermal sinus tract. We were not sure what it was. I'm not showing you the DWI imaging. This was a dermoid cyst. It was not showing restricted diffusion. The heavily T2-weighted imaging can be very useful to depict the entire tract and to show the osseous abnormalities. And of course, because of if there is any suspicion for superadded infection, contrast should be given for assessment of enhancement of dura, the cardiac one and nerve root, the peel surface of the conus, the central canal, the abscess. In this case, everything was there. Everything was enhanced. You can see the peel surface, the central canal, the cardiac one. This was a bad case of infected dermoid cyst from a dermal sinus tract. Split cord malformation, if you remember, as I said, notochord is a structure that stimulates the ectoderm to become the neural plate. So it can stimulate 2 neural plates, which can then lead to diastematomyelia or diplomyelia. Diastematomyelia has 2 hemichords, each covered with its own pia containing a central canal. And diplomyelia is basically true duplication of the cord. Most females are disproportionately more affected than males. Most of these patients, again, will have cutaneous lesions associated with it. Most of these patients present with clubfoot. Because imaging cannot reliably distinguish diastematomyelia from diplopia, people prefer to use the term split cord malformation as opposed to diastematomyelia. On imaging, they're divided into 2 types. The type 1, where both hemichords have individual dural sac, and they're often separated by either a fibrous or a cartilaginous or a bony septum, as seen here, and these patients have higher incidence of vertebral anomalies. So CT scan is very important in these patients to show the vertebral anomalies or to show the septum, as seen here. Similarly, susceptibility-weighted images or heavily T2-weighted images can beautifully depict the septum in these cases. In type 2, there is no intervening fibrous or cartilaginous septum, and the hemichords share a single dural sac, and then there can be partial duplication or complete duplication of the cord. And in these patients, the vertebral anomalies are usually milder. Moving on to chordal regression. Now, chordal regression syndrome has different names. It's called chordal regression sequence, chordal regression agenesis. It comprises a range of abnormalities in the lower half of the body, obviously including the lumbosacral agenesis or dysgenesis, along with variable involvement of lower limbs, GI tract, GU tract. And it's a cardinal feature of diabetic embryopathy. Now, imaging hallmark is that there is hypoplasia of the distal spinal cord and vertebral segment. Just like diastematomyelia or split cord malformation, they're divided into 2 different types. The type 1 has this classic we call as the blunted or wedge-shaped or cigar-shaped cord, which usually terminates higher up at T12, T11 level, usually above L1, and these patients have more extensive vertebral anomalies. The type 2, the cord is still hypoplastic, but usually terminates below L1, and these patients have higher incidence of spinal lipoma, and then they're always tethered, and they have higher incidence of tethered symptoms, but they have less sacral anomalies. Okay, so in summarizing, this is a long talk. I tried to cover as much as possible. I'm going to try to summarize some salient points. So in anatomy, normal conus should end no lower than inferior L2 end plate. The normal phylum is usually less than 2 millimeter in size, definitely normal if it's less than 1 millimeter in size. Try to always obtain sagittal T2 image for counting vertebral bodies. Try to obtain coronal T2 as a part of your MR protocol. Filar cyst, internal ventricles, or incidental findings. Ultrasound should not be performed for the setting of simple sacral dimples. Our main role in the setting of myelomeningocele is prenatal diagnosis and postoperative imaging appearance for complication. Tethered toward can be a clinical diagnosis. Also, they can present at any age with GI, GU, lower extremity dysfunction. Non-terminal myelocystocele can look like myelomeningocele. They have less severe CNS abnormalities. Spinal lipoma is extremely common in our day-to-day practice, very heterogeneous, different classification system. What is surgeon looking for? The surgeon is looking for a presence of a sinus tract, the dural defect, the width of the dural defect, and the entanglement of the nerve roots. Choroidal regression syndrome is often associated with multiple other syndromes such as OEIS, factorial GU anomalies. It's a hallmark of maternal diabetes. And the classic imaging appearance is a blunt appearing cigar-shaped cord. And with that, I want to thank you for your attention.
Thank you, Dr. Pruthi, for your wonderful presentation and beautiful images. Now the two topics are open for discussion.
Questions? Paul.
Hey, Sumit. Great talk. This is really simple, man. It's just those sacral dimples are killing me, man. So, because we get it all the time. The pediatricians, you know, they always say, you know, there's the high-risk sacral dimples and the low-risk sacral dimples, right?
Can you hear him? Something is happening in this side. That's why I confirmed. We can't hear. There's so much echo.
Oh.
Like I can't hear my voice when I was speaking. Yeah, that's better.
Is that better?
Yeah, that's better. Thank you.
So, you know, so the high-risk sacral dimples, low-risk sacral dimples, the pediatricians always tell me I can't see the base of the dimple.